I think we're going to start. So good afternoon. We do have lots of people registered that are going to be joining. So I'll just go through a couple of housekeeping issues, and hopefully by the time we start with our first speaker, everybody will be on. And I hope everybody can hear me. So welcome to today's webinar on cancer genomics, what healthcare professionals need to know. My name is Philandra. I am the lead nurse for the Central and South Genomics Medicine Service Alliance. We're really excited to have you all join us today for what promises to be an insightful and impactful discussion. So just a few housekeeping notes. The session is being recorded and will be shared with all attendees afterwards. It will also be uploaded to our website and YouTube channel for those who couldn't make it today or wish to revisit the presentations. Please turn off your camera and ensure your microphone is muted during the main presentation. And throughout the session, please feel free to add your questions to the chat. We will try to answer as many as we can during the Q&A at the end, if we have time permitting. Lastly, don't forget to complete the pre-event survey. Your feedback is incredibly valuable to us as we work to improve our future events. So just a reminder regarding your questions, if you can just add them in the chat. And I can't see anybody as I've only got one screen today. So apologies if somebody is able to let me know if anybody has any burning questions and puts their hands up. So we're going to dive into today's agenda. We've got an incredible lineup of speakers who will provide us with key insights into the role of genomics in cancer care. Our first presenter is Associate Professor David Church, who's going to provide an overview of genomics in solid cancer. Next, we have Dr. Laura Kecho, a lead scientist from Wessex Clinical Genomics Lab in Salisbury, who will be giving us an insight into the role of genomics in blood cancers. And following Dr. Kecho, we're pleased to welcome Atali Melville, the Principal Genetic Counselor, who will be talking about how genomic information impacts the people we care for and their loved ones. Then we have Donna Gillen, Senior Research Nurse with the TYA Research Project in the West Midlands, who will share some insights into ongoing research efforts in this really vital field. And finally, we're really honoured to have Amina Westwood, who is a powerful expert by experience. And Amina is going to share her personal journey and advocacy work. After all the presentations, as I said, if time permits, we will open the floor for a question and answer session. So please make sure to post any questions in the chat as we go along. So without any further ado, we will have Associate Professor David Church. Are you going to share your screen, David? Are you there?
Yeah, Phil, I will. Unfortunately, I can't drive the slides remotely.
Okay, so do you want me to share or you're going to share?
Hopefully I'm sharing the screen now. So okay, if you could give me a nod that that's the case, that would be amazing.
Yes, that's it.
Fantastic. Great. Well, very nice to meet everyone. And as Phil says, thank you all for making the time to join this webinar. I hope it's informative. I know there's a range of different healthcare professionals with us on the webinar today, and hopefully this will give something for everyone. So by way of introduction, Phil's already done it for me. So I'm a medical oncologist in Oxford, where I have a lab, and I'm funded to do research and clinical work by Cancer Research UK. I'm also the lead for Lynch syndrome for the Transformation Project for Central and South Genomic Medicine Service Alliance, and have an interest in vaccination for Lynch syndrome, which is kind of germane to some of the work that we'll be talking about. So what I've been tasked with is talking about genomics in cancer care and solid tumours more specifically, and knowing that we're all coming at this from different perspectives, I thought it might be helpful just to start off by discussing some basic concepts to frame the next couple of hours, really. So first up, I thought it would be helpful just to remind ourselves collectively what we mean by genomics. So genomics broadly defined as the study of genomes. That's the complete set of genetic material that we're born with, and also that in a cancer that is corrupted in the cancer. And so we are born with 20,000, give or take, genes in humans. And just to remind ourselves, the central dogma of biology, molecular biology, is that DNA is transcribed into RNA, is translated into protein. And variations in a DNA sequence that we're born with determine our physical characteristics. We all have different DNA sequences. We all look different. We all have different predispositions to disease. And of course, errors in the DNA sequence can alter RNA and thus alter proteins and therefore cause disease. And if we look at that in the context of cancer, we may be familiar with the concept of mutations or errors in the DNA, which can occur either that we're born with, which increase our risk of cancer. I mentioned that I work on Lynch syndrome, which is the commonest hereditary cancer predisposition syndrome, people being born with a faulty copy of a mismatch repair gene, which means they're at increased risk of cancer, up to 80% for some individuals with Lynch syndrome, or in the case of the tumour itself, alterations, mutations in the DNA that have arisen during adult life. And we know that mutations start to become acquired in normal tissue from the second decade of life, actually, which we may hear a bit more of in the subsequent talk on hem-onc malignancies. So mutations in the DNA can cause mutations in the RNA, and they can cause, in turn, abnormal proteins. And if the protein is affected in that there's a change in the amino acid sequence of the protein, or the protein is shorter than it should be, that can corrupt its function. So it can either be a gain of function where a protein starts doing something which normally would be regulated in an unregulated sense, or doesn't serve its normal function. And collectively, these mutations can cause cancer, as we'll be well aware. So what is genomics in terms of a definition that we use in healthcare? So the NHS England defines genomics as follows: the study of genes in our DNA, their functions and their influence on the growth, development and working of the body, using a variety of techniques to look at the body's DNA and associated compounds. So perhaps not the snappiest definition that you'll ever hear, but that's a broad definition of it. And genomics is a relatively new field in medicine, but the concepts have been around for some time. So if we look at milestones in the development of genomics, you'll be very familiar with the discovery of the DNA double-stranded helix by Watson and Crick, Rosalind Franklin, sadly neglected from the original paper in 1953. And then sequential progress, cumulative progress over the subsequent decades. And a couple of things that I'd just like to highlight: that in 2003, so 21 years ago now, the completion of the Human Genome Project, the first sequencing of the entire genome of the human. And this was a 13-year collaboration across multiple groups in Europe and the US, and it cost $2.7 billion at that time to sequence one human genome. Now, fast forward 21 years to where we are now, and this is even more impressive now. So this is a NovaSeq machine, the latest Illumina machine, which can sequence 20,000 genomes per year at a cost of $200 per genome. So in only 21 years, we've gone from here to here, which is absolutely remarkable testament to the progress that we've made. And we talk about Moore's law in computing, that with time, computational power doubles every year. Well, in fact, for genome sequencing, the rate of progress is far faster than that, actually. So it's outpacing Moore's law for computing, which is really remarkable. And how do we get all this information into the clinic? How can we embed genomics in the clinic? Well, this is what NHS England think. They have a Genome UK plan and three strands of it, really, which I'd just like to highlight. So genomics in medicine and cancer medicine, it would be a germane example. So diagnosis, helping with diagnosis in personalised or precision medicine. Enabling predictive and preventative care. This would be something that I'm interested in from point of view of Lynch syndrome, of course. And we'll hear a little bit more later about research. So supporting fundamental and translational research to ensure a seamless interface between research and healthcare delivery. And I encourage those of you that are interested to read this report, which has some interesting nuggets, actually, which are still highly relevant even 4 years later. So the aim specific for cancer, that we want to think about preventing and identifying cancer earlier. Early diagnosis, we know, is essential to improve outcomes. Design and pilot a new model for cancer involving multiple genomic testing. and develop technology and even infrastructure to support clinical teams, and of course genomically enable clinical trials. A key priority obviously for NHS England is to ensure as we do this we have equity of access. We don't want the services to be embedded in one place geographically in the country and not elsewhere, which is obviously a challenge we face in healthcare more generally. So that's a rather complicated schematic, but in simpler terms, I think it could be highlighted as such that at the moment for cancer care and medicine in general, traditionally we've had broad diagnosis and symptom-driven medication or symptom-driven treatment, whereby everyone with, say, a bowel cancer or a breast cancer gets the same medicine, and this traditionally has been partially effective, some successes, but by drilling down on the molecular characteristics, the molecular feature, the molecular subgroups of a cancer, we can have an individual characterization of the disease and tailor the treatment to match both the individual's genetic makeup they were born with and also the genetic makeup of the cancer. So we have more precision treatment and better outcomes with fewer side effects, of course. So that's the vaulting ambition that we're seeking to realize with genomic medicine for cancer care. And it would look something like this. So this is a paper from a few years ago from the Memorial Sloan Kettering, which is a big cancer center in New York in the US. Very, very well resourced. And for some time, they've done a large panel-based sequencing that they worked up at a cost of nearly $500 million over several years. And their workflow looks something like this. So the patient has a normal consult. They have a tumor sample and a blood sample taken. It's sequenced on a DNA sequencing machine, large panel sequencing, which will give you mutations, alterations in copy number of genes important for cancer, and rearrangements of genes which are important for cancer. This is then analysed bioinformatically and really digested and pressed in a clinician-friendly format, whereby you get a report of variants that are, as we refer to in the jargon, actionable. So alterations in DNA that might mean a patient is more or less likely to respond to a particular therapy. And when they looked at this over their experience of several years, they found that actually there was a substantial fraction of cancers that had actionable genomic alterations within them. And they were able, with this large panel sequencing, to match 11% of their patients to a clinical trial for a specific therapeutic, targeting the alteration in their DNA, and also identified patients who are at increased risk of adverse drug reactions, which is something that's very important, as we'll be well aware of. And so where are we in NHS England working towards this? So we do large panels for many cancers, as you'll be well aware. And we also have the ability, in theory at least, to do genome sequencing. And this would be something that would be good to follow up on the discussion, on. So you may be aware that for paediatric cancers, they can all be whole genome sequenced. And for adult tumours, a subset of cancers can be. So neurological cancers, triple negative breast cancers, carcinoma of unknown primary, high-grade serous ovarian cancers and sarcoma all have funding for whole genome sequencing in terms of the sequencing. Now, where the wrinkle is that the sequencing is funded, but the pipelines to get the samples and also analyze the data are either partially funded or not always funded. So that does create a challenge for us as healthcare providers. You'll be well aware that panel testing, gene panel testing, has been commonplace for many cancers, including, for instance, colorectal cancer, which I treat, but also melanoma, lung cancer, and other common tumor types. So that's a diagnosis in advanced disease. We're allowed to do whole genome sequencing on any treatment refractory solid tumour. Of course, there are issues about when you do that, because when patients have treatment refractory disease, they may not have long to live in the absence of effective treatment. So you might find that the patient is moribund before the genome sequencing result is back, and that's a challenge that we face and we'll have to grapple with over coming years. We can also do panel testing for NTRK fusions, where there's specific inhibitors for any solid tumour. So sorry, this has got corrupted by the presentation, but the take home from this slide is these are the whole genome equivalents that we're doing in Central and South over the last year and a half. And what you see here is that whole genome equivalent is roughly a paired normal in cancer is about 3.5 whole genome equivalents. So divide the numbers here on the y-axis by 3.5 to get the rough number of genomes or patients that we're analysing. And what you see here, take home really is just that the trend is ever upward increase in the numbers of genomes genomes that we're doing. So it is coming online, and we are getting information from it. Unfortunately, I can't share with you the clinical relevance and actionable alterations found in these data that I'm showing you here. But what I can show you is this nice paper published by Rupa and Muragescu from analysis of the Genomics England 100,000 genome sequence cancers. So this is a big government-funded project which I analyse colorectal and endometrial cancers within. And what Naropa did and the team did was to analyse the genome sequencing from a very large number of cancers, more than 10,000, collected with patients recruited under routine care in the NHS. So they consented for sample collection. The DNA was extracted from their blood and from their tumour. It was sequenced. The DNA variants were called and automated their interpretation, and then they were reviewed, discussed at genomic tumor advisory boards, which is something we're rolling out, and then the evaluation was whether they affected patient management. And these are the tumor types that were analysed in this very large study. And these are the results. So busy slide, so I don't expect anyone to remember all of this, but just to highlight a few key points which are clinically relevant, is that mentioned about NTRK fusions and specific kinase inhibitors that can target these very effectively. So these were found across multiple tumor types. So actionable variants in terms of a treatment here. We also find here signatures, mutational signatures. So these are, if you will, genomic scars of processes occurring in the cancers that you can read out in the whole genome sequence data. You actually can't get these reliably from panel sequencing, but you see here that in ovarian high-grade serous cancer, this mutational signature of homologous recombination deficiency, so this is a deficiency in DNA repair that makes cancers that carry it ultra-sensitive to PARP inhibition. So an actionable alteration picked up by the genome sequencing in this subset of ovarian cancers here. You find in the germline sequencing, so this is the DNA that the people were born with, the individuals recruited to the project were born with, you find germline mutations that have increased their risk of cancer. So amongst these are a number of individuals who the genome sequencing revealed they were born with a faulty copy of a mismatch repair gene, so they have Lynch syndrome, which caused their cancer. So we could use this to screen people in the clinic or in routine practice to see if they have Lynch syndrome or other predisposition syndromes. And finally, we talked in the Sloan Kettering data about adverse drug reactions and predicting those. You see here the fraction of patients who had DPYD toxicity variants. So these have loss of function variants in DPYD, the gene essential for metabolizing fluoropyrimidines, fluorouracil and capecitabine we use commonly in the clinic. Patients who have these variants are at substantially increased risk of life-threatening toxicity. So this was picked up in the genome sequencing as well. So although the individual fractions of these alterations are maybe not that high, particularly for things like NTRK fusions, when you add them up, you end up finding an actionable alteration in a substantial fraction of patients. But looking at this kind of plot, you may think, wow, my goodness, there's so much data there. Where do I start? And I think that we're all faced at the moment with this tsunami, if you will. It's a bit of a hackneyed term, but the amount of data you get from genome sequencing and modern technologies coming online is absolutely overwhelming. And I think you can feel like you're being swept away by this tidal wave of genomic data, and we're not really able to deal with it. That help is at hand. As a fan of Dad's Army, I couldn't resist putting this in, so please forgive me. Obviously, this will mean nothing to anyone under the age of 50, but I couldn't resist. So I'd just like to offer you, one opinion which is personal. So happy to discuss it in the Q&A later, and two facts. The first is that genomic medicine is evolution, it's not revolution. We've been doing this for some time, and many of us on the call will be familiar with the fact that for the last 12 years, we've been using molecularly targeted therapy, for instance, for melanoma. So vemurafenib targeting the BRAF V600E mutation, leading to remarkable outcomes or temporary remissions of melanoma in patients who carry this particular variant. So this is a specific inhibitor of the mutant protein that the cancer-associated mutation causes. And also for around the same length of time, we've been using KRAS, latterly RAS, including NRAS mutation testing of colorectal cancers to guide whether we use anti-EGFR therapy. And so we do this routinely in the clinic. We don't even think about it now. But when we started out, it was all brave new world. And now it's just something we don't even blink an eye when we do. And I think as we roll out genomics, so this will be more and more the case, although there are obviously challenges which we shouldn't shy away from. So that's my opinion. The second is a fact that there are fantastic educational resources available for all of us. And I just highlight some, and I hope we'll be able to distribute some links later in the material supporting this webinar. But just 3 excellent resources we have through NHS England. And the other fact is that the GMSA, we're here to support you. So Central and South, we've got a big initiative in education, of which obviously this webinar is part. And we also I'd just like to highlight the excellent website that we have here, which really signposts educational resources, no matter whether you're a medical doctor or a nurse or a pharmacist. It's all there. It's all useful information. So I encourage you to visit there and mine it for all you can, if you're interested, of course. So this is how I see the future, as we all become genomic savvy with the educational resources and the experience that we'll gain, looking out over the calm sea of genomic possibilities. And this is the brave new world that we're facing. And I think it's exciting rather than frightening. I really do. To just sum up in the last, or highlight in the last few minutes, just some real world cases. It's all very well looking at data, but what does this mean in the real world? So one case, a man with advanced prostate cancer. So this was a chap who was in his 60s at the time of this case. He had advanced prostate cancer. He'd been through all therapeutic options, hormone therapy, chemotherapy, and his chemotherapy was stopped after his markers increased, and there was a radiological progression on this scan, and his markers continued to increase. So he had whole genome sequencing done in Oxford under a project that was funding genome sequencing at that time. This is going back a few years now. And the genome sequencing identified a deletion of the tumor suppressor BRCA2. So this is the risk gene for hereditary breast and ovarian cancer, and also associated with homologous recombination deficiency, which we've highlighted in the Genomics England data just a moment ago. So on the basis of this, he had whole genome sequence guided treatment with carboplatin. We know that patients who have homologous recombination deficient cancers are more sensitive to platinum, and he responded very well to that. So he would not have had this therapy if it hadn't been for the genome sequencing and the identification of this BRCA2 deletion. So he had a good response to that, biochemically and radiologically, and then he went on to a maintenance PARP inhibitor, which, as I've shown you, can be exceptionally effective in this subset of patients. And he had a long-term period of disease control as a result of that, and that brought him an extra 13 months of good quality extra life, which he wouldn't have had if it hadn't been for the genome sequencing. So a meaningful difference to this man's cancer care as a result of the genome sequencing. The second case is a woman with ovarian cancer, 57 years old at the time of diagnosis, primary peritoneal carcinoma, which is essentially an ovarian cancer outside the ovary. She had standard of care with pre-op carboplatin and paclitaxel, had debulking surgery and then post-op chemotherapy. But BRCA testing is done routinely in ovarian cancer to see if patients have had their ovarian cancer because they've been born with a faulty copy of a BRCA1 or 2 gene. And it found this variant here. So this is a missense alteration, so a change in the protein. So unlike those stop variants where the protein is shorter and you know it's dysfunctional, it's really uncertain whether this would be functional or not. Did this cause her to have her ovarian cancer, or is this just a variant of no significance at all, just something that is an aside to her cancer and her treatment? So the question was, could we use genome sequencing to give us some more information on whether this was a significant finding or not? And so genome sequencing was done again within the Genomics England project, and this detected the BRCA2 alteration that was picked up in the reflex testing, and also found that it was present in greater number in the tumour than it was in the normal, which suggests that there might have been something called a loss of heterozygosity, so loss of the normal copy. So there was only this altered copy in the tumour, which suggests that it might be functional. And in addition to that, the mutational signatures, which I've shown you a moment ago, showing that the readout of homologous recombination deficiency, of DNA repair deficiency, was present. So this suggested that this alteration in BRCA2 was indeed functional, and that its loss in the tumour had made the tumour DNA repair deficient and consequently sensitive possibly to PARP inhibition. So based on that, this variant was reclassified. She had a revised diagnosis and she was able to go diagnostic counselling and management of her breast cancer risk and also screening of her family. And it changed her treatment as well because they were able to get a PARP inhibitor for her treatment to increase the chances that she'd be cured from her ovarian cancer. So to sum up in the last minute, so genomic medicine, I would argue, and happy to discuss this in the Q&A, it is really just medicine. So we think about management of edema from 200 years ago to the present. 200 years ago, an eminent physician in the US wrote that about diuretics for edema happens unluckily, that none of these are very certain operation, neither is it well known why they sometimes succeed and why they so often fail, or why one medicine should prove of service when another does not. Fast forward 200 years, and now we don't think of edema as being one disease, obviously. We think of it being a manifestation of multiple diseases, and we use multiple tests to classify or to define what's caused the edema and what the best management of it. And if we think about the same for cancer care at the moment, okay, we think about tumour types and maybe a little bit more sophisticated than this. So I put this in firmly with my tongue in cheek, but I think we could say perhaps for those of us that practice and give chemotherapy or drug treatment for cancer, you know, it happens unluckily that none of these are a very certain operation. I can see some commonalities there, I have to say. Fast forward to 10 years from now with genomic medicine and, you know, other technologies coming online, and I really hope that we'll be in a better situation and look back on where we were as, you know, the bad old days. But it is a story that will be continued, of course. And I think just one follow-up, it's important to manage our expectations, you know, with this well-described peak of inflated expectations and trough of disillusionment. I think sometimes we may be here with genomic medicine, but as it comes back up to the plateau of productivity, we should be a little bit happier. And I think the key thing I want to get across is evolution, I would say, and not revolution. You know, we're not reinventing the wheel, it's just applying new technologies across the board to improve precision cancer care, which obviously is an aim we would all agree is a worthwhile one. So happy to take questions at the end. We'll signpost some links which we'll follow up on. And thank you all very much for your attention. I'm sorry I've overrun by a minute and a half. I do apologise, everyone. Thank you.
Thank you very much, David. That was a great overview. I think we're just going to go forward now and continue. So Dr. Ketcher, are you ready and are you happy? Are you going to share your slides or do you want me to move the slides for you?
No, I think I can. Sorry, I think I can. One second. Can you see my slides?
Yes.
Yes, great. Well, thank you so much for inviting me. My name is Laura Chiecchio, and I am a clinical scientist working in the EMONC section here in Salisbury at the Wessex Genomics Laboratory Service. So I will give an overview of how we use genomics in the context of hematological malignancies. And so these are my outline. So I will talk about the role of genomics in the management of hematological malignancies, how do laboratories set up and select appropriate genomic testing, a diagnostic pathway for hematological malignancies, and I will focus mainly on liquid biopsies because otherwise it becomes very complicated. I will give an example of a clinical case, and I will use a patient with acute myeloid leukemia. I will just briefly talk about the role of whole genome sequencing in the context of hematological malignancies, and then there will be my conclusions. So when we talk about hematological malignancies, well, they encompass a wide variety of clonal neoplastic disorders. They can be chronic, slowly progressing diseases, but a lot of them are acute leukemias or high-grade lymphomas, and with an aggressive clinical course. And they have to be treated within days or maybe a couple of weeks from diagnosis, because otherwise the patient is at risk of death. All these malignancies derive from blood cells, but they derive from blood cells at different stages of differentiation. So if we talk about acute leukemias, they will usually derive from blast cells or very early precursors, while some of the other malignancies, more chronic diseases, will derive from cells which are at a more mature state of development. When we talk about, for example, chronic lymphocytic leukemia or multiple myeloma, they derive from cells which have gone through all the process of differentiation from stem cell to active and functional developed cells. They've been very well characterized from genomic level, and this is due to the fact that the material is very easily accessible. You can take a blood draw. It's much more difficult to actually take a biopsy from a solid cancer, depending on the site. Usually the quality of the material is really high quality, so you will have a really good quality DNA and RNA, and also you can culture cells quite easily. But also because a lot of research has been fueled by really exciting novelties that have been discovered in the last probably now 60 years already. So we know a lot about them, but how do we use actually this information in the context of a clinical service? Well, since 2018, there has been the implementation of the National Genomics Test Directory, and this is in England. And the aim of the test directory is to facilitate a standardized approach to testing and provide equity of access to advanced and clinically relevant genomic tests. So there is the genomic test directory, which is available to everybody, and this is the website. There is one for rare disease and is one for cancer, and within the cancer one, there is a specific one which is just related to hematological malignancies. It is very much a list of tests, and I will show you just a snapshot in the next slide, but they will list the individual tests which are commissioned by NHS England and which are allowed for the appropriate disease group, the technology by which tests should be performed, and the patients who are eligible to access the test, each of which is coded. The test directory is not a fixed document, but is continuously updated. Usually we have had so far a couple of updates per year, and clinicians, research groups, or professional bodies are allowed to submissions for new tests, for new clinical indications, particularly if associated with, for example, a NICE approval for a new drug. And all these submissions are going to go for a peer-reviewed, and obviously they will look at the benefit of introducing a new test, the cost associated with that, whether the technology is already available within laboratories, and how much is going to be need a laboratory to be implemented or changed in order to provide this test. And this is just a snapshot from the EMONC test directory. It just shows some of the tests which are associated with acute myeloid leukemia. And you can see that the first one, which is coded M80.1, corresponds to whole genome sequencing. And then as you go down, you can see that there are single genomic tests, panels of genes, panels of fusion genes, RT-PCR, and then you will have karyotype and a lot of fish testing. So it can involve multiple investigations, it can involve multiple genes, gene panels, targeted gene testing, but also a number of different technologies. And obviously the technology that you use will very much depend on the stage of the disease, because obviously you don't have to use a very sensitive technique if you analyze a patient who has just been diagnosed, because possibly the sampling that you're using has got a very high level of tumor burden, but it's a very different scenario when you actually want to monitor the disease following treatment for these patients. And I will talk a bit about that. So how does genomic inform the clinical decisions in hematological cancers? Well, I would say that these are the 5 main categories of why we use genomics. First of all, is to support the diagnosis of hematological neoplasm. And this is because in some, particularly with chronic conditions, and we've talked about all the patients, sometimes it's not easy to actually, for the clinician to say whether the patient has got an hematological condition, because some of the symptoms like anemia or fatigue or sometimes bleeding, they actually could be caused by other factors like, I don't know, the interactions with other drugs, maybe the nutrition, or maybe other symptoms. Therefore, the finding of a clone with genetic abnormalities, specific genetic abnormalities, can actually support a diagnosis of an MDS, which is a myelodysplastic syndrome, or a myelodysplastic syndrome myeloproliferative disorder. So in reality, genomics, if this is a bit different from solid tumors, can actually help supporting a final diagnosis. Genomics is very important in the classification of hematological malignancies, and we use 2 different classification systems. One which is the World Health Organization and is now on its 5th edition, which was published in 2022. And the second classification, which was just published the first time in 2022, is the International Consensus Classification. They are very similar, but they have some differences, and we have to look at both. So this is what we use as a Bible when we do any testing, and because within the same disorder, you can have actually many different entities or subtypes based on the presence of specific genetic abnormalities. We use genetic abnormalities for prognosis because we'll provide information on overall cancer outcome, and this is independent from other clinical aspects. And also we use it for either predictive or actionable biomarkers. So they can predict, we use genetics to predict the response or lack thereof to established or novel therapies. And we can use genetic abnormalities actually in the certain scenarios for the selection of specific targeted therapies like the tyrosine kinase inhibitors in the context of CML or the ATRA in the context of acute promyelocytic leukemia. And the last but very important way that we use genomics is actually to monitoring the disease following the treatment. And this is because molecular gives you the possibility of actually monitoring very minimal amount of residual disease, which are not visible by microscopy and sometimes not even by flow cytometry. So what is a diagnostic pathway for hematological cancers? And here I'm very much focusing on the liquid biopsy, so leukemias rather than lymphomas. So usually when hematological malignancy is suspected based on clinical symptoms and blood counts, there is a morphological assessment of peripheral blood or the bone marrow. And usually this is followed by immunophenotyping and genetic testing. All these disciplines really have to communicate very fast and very precisely because the type of testing algorithm that the genetic laboratory will start will very much depend on defining the morphological assessment and the immunophenotyping. And at the end of all the investigations, all the results from all the above tests need to be put together. And this should be embedded within the specialist integrated hematological diagnostic service through the provision of an integrated report to clinicians, which will include the cytomorphology, the immunophenotypic profile, and all the genetic tests that have been done. And when I talk about the genetic testing, we can talk about molecular genetics, very fast and targeted testing, or large panels, but we still use, as I said, a lot of fluorescence interpretation, and we still use a lot of cytogenetics, unlike in solid tumors. So I will go through a clinical case just to show you what could be an algorithm. And this is probably one of the most complex algorithms that we do in the concept of acute myeloid leukemia. So this was a 50-year-old woman who presented with multiple urinary tract infections, fatigue, and loss of weight. So the complete blood count showed an increase in white blood cells, but also decreased in hemoglobin and decrease in platelets. And the immunophenotyping, which was done on the blood, detected 21% of blasts, which are very mature cells. And this is the profile, the immunophenotypic profile which was detected. And this is consistent with the diagnosis of acute myeloid leukemia. And I just give you some background about acute myeloid leukemia. It's a very heterogeneous disease, both from a clinical point of view, but also from a genetics point of view. And it's when you look at it from a morphological point of view, you can see that there are large numbers of mature cells, the so-called blasts, which are produced, they fill the bone marrow, and then they are released into the bloodstream. These blasts should normally, in a normal person, develop and get to further stages of maturations to actually make neutrophils, platelets, and white cells, which circulate in the blood and fight infections and all the functions, or they avoid bleeding. But unfortunately, because these blasts, and due to epigenetic and genetic mechanisms that occur in the blast cells, they are just unable to mature any further. So there are no mature cells, and there is an increase of blasts both in the bone marrow and in the blood. And this is what you see when you look at, this is just a bone marrow triphyline biopsy. These are all blasts. You can see a monomorphic sheet of very similar cells. And just to give you an idea, this is from the WHO classification. These are all the entities of AML which are currently recognized in the WHO according to genetics. So you can see how genetics plays a very important role in the definition and classification of AML. All these are AML, but they are all driven by different genetic abnormalities. And what the genetic laboratory has to do is actually to identify these genetic abnormalities for accurate classification, because obviously, based on the classifications, the patient will be treated accordingly. And so when we receive a sample following a suspected or confirmed diagnosis of AML by immunophenotyping and morphology, really we have to start a range of tests. And these are all the tests that we start at day 0 when a sample comes through the laboratory. We will start culturing to provide a karyotype. We will start urgent FISH. We will start a single gene testing for these genes. We will also start RT-PCR, which is reverse transcription polymerase chain reaction to look at specific fusions, but we will also start a large panel which looks at about over 50 genes which are associated with myeloneoplasia. And there is also the possibility of submitting samples from AML from both pediatric and adult patients for whole genome sequencing. But whole genome sequencing at the moment does not represent, and I will explain why, standard of care testing for these patients. And here I just put what are the turnaround times which have been approved by NHS England. And these turnaround times are relevant because of the clinical decision making that clinicians have to make. So all these tests will have to be reported by day 3 or sample receipt by a genomic laboratory. And then there's going to be some at 7 days and some at 14 days. And whole genome sequencing should be 42 days from analysis. So what happens in reality? So you will have a sample which is going to be collected, either is a bone marrow sample or a blood sample in the clinic. The first thing that happens to the sample when it comes to genetic laboratory is counted, because we have to make sure that the sample is adequate to do all the tests that we want to do. So we count the sample, and if we believe that the sample is suboptimal or not enough, we will have to contact the clinician and ask for additional sample. Part of these samples would actually follow the route of culturing. We still do culturing. This go through 24 to 48 hours. And this is in order to be able to provide, as I said, a karyotype. We still look at chromosomes under the microscope. And we also use the culture material to do quite a lot of fluorescence in situ hybridization. I cannot really describe all these techniques because of the matter of time. But these are based on cultured cells. And then there is a second component of how we actually use the sample, which with the extract DNA and RNA extraction. And on this, we will do single gene target is tested, and then we will do NGS for large panels. So if we go back to this, the patient that I described previously, so by day 3, we should have like a result on the presence or absence of mutations in the gene called NPM1. And in this case, we found a pathogenic variant in the NPM1 gene. And this was done by a very targeted urgent test, not NGS, it's fragment analysis. And this will classify this AML as AML with NPM1 mutation according to the WHO. These classifications will not change no matter what other findings we're going to find. And so far, this is associated with a favorable prognosis, meaning that this patient is likely to be cured just with chemotherapy alone. However, at the same time, we have to provide information on another gene, which is FLT3. FLT3 cannot really classify that AML, but can change the prognostication of the NPM1 mutation, in the sense that the co-occurrence of FLT3 will actually make the prognosis from favorable to intermediate. And more importantly, the presence of a FLT3 ITD would actually make this patient eligible for a targeted inhibitor, FLT3 inhibitor, to be added to the intensity chemotherapy regimen. This patient did not have a FLT3 ITD, so at the present, at day 3, the prognosis remained as favorable. However, this is still not enough, in the sense that we still have to be able to provide a karyotype, because the presence of adverse cytogenetic abnormalities would change the prognosis from favorable to adverse, and this has to be released at day 7. This patient had no cytogenetic abnormalities, so the carrier was normal, which in this sample is quite common in this type of leukemia. So the favorable prognosis remains. There is no evidence that the patient is eligible for any target therapy, but is whether eligible for if fit enough for chemotherapy. And so the next thing that I want to mention is what I mentioned at the beginning, that genetics is really important for the monitoring of hematological neoplasm. Not all of them, but where we find an informative marker. And in this case, NPM1 mutations represents an informative marker because they actually are drivers of that AML. So if we see this diagram on the left, this is just what so this is what morphology can detect. So if we have a patient with AML and the patient is treated, then the morphological assessment of the bone marrow can actually see whether the patient is responding or not to the therapy. But really, the limit of detection of morphology is only really 5% of blast. Below this level, anything that happens below is what, from a morphological point of view, there is no difference. The patient is in complete remission, and there is no additional information can be given. Whether when you lose molecular techniques, you can see that, and this is, for example, by RT quantitative PCR, you can see that this is monitoring this patient by both blood and bone marrow. And you can see this is diagnosis. The patients the level of disease goes down, and this is the 5% that would be recognized by a morphological assessment. But you can see that below this level, there are lots of different stages of the disease, and the level of the disease burden changes considerably, with the application of therapy. But the fact that you can see these changes below 5% means that you can actually act on the disease and on the patient at the time where the patient is actually still very fit and the disease is actually not manifested yet from a morphological point of view. And you can see that different therapies have been applied to the patients even before the disease was still visible in the marrow. And at this point, the patient had a bone marrow transplant. So this is a stem cell transplant. You can see the disease goes down again, almost at an undetectable level, but then it goes up again. And this is when the patient has relapsed. But again, the clinician could actually decide to give donor lymphocyte infusions even before the disease was visible by morphology in the marrow. So this is one of the major advances of how to use genomics in the context of hematological disorders. Obviously, not every patient has a molecular marker which is reliably monitorable, and therefore when there is no molecular markers, usually flow cytometry, this is a specific flow cytometry for MRD, is used. Whether the level of sensitivity that this can be achieved by genetic technologies is much greater. So I said I was going to touch about whole genome sequencing because all pediatric patients with hematological malignancies are eligible for whole genome sequencing, and also a number of adult patients with hematological malignancies, all the patients with acute leukemia, and some of the other patients with mixed phenotype, for example, are eligible. And I said that this is not currently standard of care because obviously this is not an accredited test, but also because the major problem with whole genome sequencing is that you have to provide a normal germline sample. And obviously for solid tumors, this is much easier because you have your DNA from your solid tumors, and then your germline sample is going to be the blood. So you can actually take the blood pretty much at the same time you have your tumor sampling, you can match them, you can send them for sequencing at the same time. But with hematological malignancies, it's more problematic because actually the blood is actually the tumor. So would you send as a germline sample? Well, ideally you would send, for example, DNA extracted from cultured fibroblasts. Whether you will have to take a skin biopsy, you will have to culture the fibroblasts. It may take about 2 to 3 weeks to culture the fibroblasts to actually have a pure population of cells from which you take a sample. And this then has to be matched with your DNA from your tumor that to be tested to sequencing. So we're talking about weeks down the line. And also in some cases, particularly with children, there are some centers which are not get up to actually take skin biopsy. So what they are doing is they're waiting for the patients to be in remission, and they will take a blood when actually there is minimal or no disease in the blood, and they will use the blood as a comparison germline sample for the tumor. However, again, you will have to wait until the patient is in remission following therapy. So it can only be used for clinical management of patients who have to be dealt with in a matter of days or weeks. So although this is very informative, it gives you a complete full genomic profile of the patients at the moment, in its form cannot be used. But as a part of the network of excellence, there is a project in progress in Oxford to make it possible to use rapid whole genome sequencing, only looking at the somatic component, so the tumor component. And there is, well, the aim is actually to provide the data in about a week. And this could potentially be amazing in the sense that you have obviously a very comprehensive genome profile of your tumor, but also the fact that you probably will not have to do so many different tests to actually come and obtain the same results. So this is ongoing, but this is very exciting. And obviously this is mainly done for acute leukemias, both in pediatric and adult patients. So whole genome sequencing at the moment in its current format cannot be really used for clinical management, but a new format which is called a rapid whole genome sequence, just using the tumor component, is actually investigated at the moment in Oxford, and hopefully it will be available in the, well, maybe next year or the following one. So in conclusions, genomics is fundamental for the management of hematological neoplasms, together with morphology and immunophenotyping, and all these disciplines really have to talk together and to be combined. None of them can actually exist in isolation in this context. The diagnosis requires good communications between all these disciplines, as I said, and as I said, at the moment there is a broad range of genetic testing that can be required. All the genetic testing which are relevant for the management of hematological malignancies are within the National Genomic Test Directory, and they are funded by NHSE. As I said, they have to perform swiftly, and also the turnaround times are recommended by NHS England. And the field is continuously evolving, and the whole genome sequencing was just an example. Thank you.
Thank you, Dr. Kiekio. That was really fascinating. I don't know if you're able to stay until the end, and hopefully we'll have some questions. But otherwise, we can direct the questions to you as they come. Yeah. And I suppose just a reminder to everyone, if you do have any questions, please add them to the chat. So our next speaker we have now is Atali Melville, who's our genetic counselor from Wessex Clinical Genetics. Atali, are you ready? And do you want me to do your slides, or you are happy to share?
I prefer to share, if that's okay.
Carry on.
Is that coming up okay?
Well, I'm waiting. I've got your main screen at the moment. I don't have your slide. Here we go. If you put it in slideshow.
It is in slideshow for me. Is that okay? Great. Okay. Thank you.
Thank you.
So I'm one of the principal genetic counsellors based in Southampton, and I'm going to talk to you about genetic testing and counselling in the cancer genetics context and the implications that this has for patients and families. So firstly, it's just to talk to you a little bit about how we accept referrals into genetics. So we receive referrals from GPs or those in secondary and tertiary care. And this is just an example of a referral that we might receive asking us to see a patient who's been diagnosed with breast cancer at 45 years of age. For all the patients that we see in cancer genetics, we do ask people to complete a family history form, and that allows us to assess the family history, because we are not only dealing with the individual who's been referred, but about the whole family. So we ask people to complete this with as much information as they can, and from that we try to confirm as many of the relevant cancers or bowel polyps We may access cancer registries or histology from the relevant hospitals. If those patients are still living, we do need consent from them in order to do that. And as part of that, then we make an assessment of the family history. And if we feel that the family history is not suggestive of an inherited predisposition syndrome, then we will usually write back with our recommendations. It may be that they're at population risk or at moderate risk, and they can still access some additional screening. Or it may be that we do feel that genetic testing would be warranted or further discussion, and so we will offer to see them in an appointment. So we have a variety of ways of offering genetic counselling. We do face-to-face appointments in their local genetics clinics, so in their local hospitals to where they're living. We also have telephone and video clinics. And we always start by setting the agenda, so discussing the referral that we've received, asking the patients any queries they may have, and also asking them to set their own agenda about what they're hoping to get out of the appointment. So in genetic counselling, it's very much about patient focus. We will always review the medical history of the patient, including any cancer diagnoses they may have had. And an integral part of genetic counselling is assessing their mental health in order to establish whether they may need any additional psychosocial support. And then the second part is assessing the family history. So we will look at both maternal and paternal side of the family, looking to see who has been affected, how many relatives, what types of cancers they've had. And then again, we assess the likelihood of there being an inherited predisposition to cancer. If we're able to offer genetic testing, if they're eligible for genetic testing, then there are two types of genetic testing that we offer in cancer genetics. The first is diagnostic and the second is predictive. So in a diagnostic test, it is exactly what it says. We are offering testing to either that individual if they've had cancer or a relative with a related cancer to see if we can identify an inherited predisposition syndrome. In predictive testing, it's where there is already an established condition in the family, and we are offering them a test to see whether they are at an increased risk themselves of inheriting that specific variant, and therefore whether they need to access additional screening or surgery. So in a diagnostic genetic test, if that individual has had a related cancer, they may be eligible to undergo genetic testing. And before we offer any blood test, we will discuss with them the implications of that. So more often than not now, we're not looking at a single gene, but we're looking at a panel of genes, multiple genes associated with that specific cancer. So it might be genes associated with breast cancer or bowel cancer, for instance. There are three possible outcomes in a diagnostic genetic test. Either we find a pathogenic variant, so one that is associated with the cancer. We may not find any variants at all, or we may find variants of uncertain significance, and David touched on this in his talk, where we're unsure if at that stage that particular variant is benign, harmless variation, or whether it is indeed associated with the cancer. And we will also talk about the implications of each of those outcomes, not for the individual and also for their relatives. So we would talk through what are the cancer risks associated with that particular genetic variant, what screening may they be able to access, so whether that's additional mammograms, breast MRIs, bowel screening through colonoscopies. And there will also be the option of some risk-reducing surgeries, for instance, removing a womb or ovaries. In predictive testing, it's very targeted. So that is where we've already identified a genetic variant in a family, and we're offering them testing for that specific variant. So we're only looking at the variant in that specific gene, and there are only two outcomes. Either the variant is present or it's absent. And again, we'll talk through all the implications of that, which is similar. There's a couple of additional aspects to that. One of them may be insurance. So some patients ask us, what are the implications of having a genetic test on their life insurance? And I will always direct them to the Association of British Insurers website, where there's a code at present between the government and certain insurance companies that means that they don't need to disclose predictive genetic test results to their insurance company. And in all genetic testing, whether it's diagnostic or predictive, we discuss the psychosocial aspects around the test. And this is really integral to genetic counselling. So even if a genetic test is available, is it something that they even want to embark on? There may be good reasons why it's not appropriate to offer genetic testing. Or is now the right time? For instance, in a predicted test, they may be just about to move home or leave or move house, and it may not be appropriate right now to proceed. And so sometimes it's about the appropriate time. We ask them about how they'll feel with the possible test outcomes and who they'll share these results with. And often that is a real consolidator for people, in that if you are asking them about who they're sharing the information with, it can reveal estrangement within families, any barriers that there may be to sharing information. So before we offer testing, we try to discuss with them how they might share that information and with whom in the family, even before they've had the test, so that relatives are aware that this information may be coming their way as well, because it may have implications for them. We'll ask them what they might do with the information. Will they do nothing? Is it for information to pass on to relatives? Is it to access extra screening or surgery? And then we ask them about what support they currently have or what they may need in order to live with this diagnosis that may be coming. And there are all sorts of emotions that come with genetic testing, including guilt and anger and stress, as well as relief sometimes. So some of the practical aspects of genetic testing: if someone wishes to proceed with testing, we will go through the record of discussion, and some of you may have seen some of these. It's a summary of the discussion that will have taken place in the appointment. We arrange for the blood sample to be taken, and then a very important aspect is that we arrange how the patient would like to receive their results when they become available. We always make sure that that is very secure, and that we don't say, well, we'll write to you if it's negative, but we'll see you in clinic if it's positive, because then patients will ultimately know their result before they come. So there are options. They can come back to clinic to receive their results. They may wish to have a telephone or video appointment, and some patients prefer to have their results by letter. We'll always write a long summary letter at the end of all appointments, summarising what we've discussed, what the next steps are, and copy that to the GP and referrer. So once the results are available, then we'll ensure that we pass on that result in the way that they've asked. And it may be that at that point we do make a diagnosis of an inherited predisposition syndrome. So we'll offer appropriate support and signpost for support if necessary. We'll refer for any appropriate screening. We'll discuss any surgical options and refer on appropriately. And we may offer that they can enrol into research. There may be some particular drugs that they may be eligible for. There may be predictive testing that we can offer to at-risk relatives, so siblings, parents, children, and the wider family. And we will offer them a letter to pass on to their relatives to share that information. And then we'll offer appropriate follow-up. So that may be to speak to them in a week or a month or a year, depending on how they've received that information. So just a little bit about some of the cancers. Generally, the vast majority of cancer, as you will know, is occurs sporadically, but only about 5 to 10% of all cancers are due to an inherited predisposition syndrome. So it's only a small proportion, hence why we have criteria for referring patients, because the vast majority of cancers are not things that we need to see in clinic. So we have local referral criteria for when and how to refer patients to genetics, and most genetic services will have the same on their websites. But a really good source of information, as been discussed earlier, is the National Genomic Test Directory. This is revised frequently, and it's a really good overview of what tests are available for specific conditions, not only cancer, but there will be very specific criteria. And so that is about the criteria we use for testing, but it's a good guide for who you might want to refer in to us. So this is one of the specific pages in the test directory for inherited breast and ovarian cancer. We call it R208. Some of the criteria will be a lady who's been diagnosed with breast cancer under the age of 40, if there's bilateral breast cancer under 60, triple negative breast cancer under 60, a male with breast cancer at any age, and various things there. And the 7 genes that we look at in R208 are BRCA1 and BRCA2, which I'm sure you've all heard of. These are associated with high risk of developing breast and ovarian cancer, and PALB2 is also included in that. And then there are variants in 4 genes that have a more moderate risk of developing breast and ovarian cancer: ATM, CHEK2, and RAD51C and RAD51D. This is our leaflet that we currently have, which includes some of the cancer risks associated with carrying a BRCA1, BRCA2 or PALB2 gene variant. And as you'll see here, the cancer risks for women carrying any of these genetic variants is significantly increased compared to the population risks. There is also an increased risk of either male breast cancer or prostate cancer with some of these genes. So there are implications for both male and female relatives in the family. So a little overview of what the implications are if a person carries a BRCA1, BRCA2 or PALB2 gene variant. As I alluded to in the previous slide, this can alter their cancer risk significantly. So if somebody presents with breast cancer, they've had a genetic test, they now carry a BRCA2 variant, we're also explaining to them that they also have an increased risk of ovarian cancer. So we've already discussed those before they've had their genetic test. But this can be quite troubling for some patients, understandably. Depending on what gene they carry, they may have access to targeted drug treatments. You may have heard of pharmacogenetics, and that's really what that means. And so access to things like PARP inhibitors, which is open to patients with breast, ovarian, prostate, and pancreatic cancer with some of these gene variants. Screening is a very large aspect of what we can offer for patients. There will be extra breast screening that starts at the age of 30 and goes right up to 70 and beyond. And so that's annual breast MRIs and mammograms, and also annual PSA blood tests for males who carry a BRCA2 gene variant, and sometimes in BRCA1 as well. This can be considered. There isn't any screening for ovarian cancer, so one of the main aspects of managing ovarian cancer is to consider having ovaries removed. Women can also consider having their breasts removed in the form of bilateral risk-reducing mastectomies, and there's also chemoprevention, so some women will be offered tamoxifen to reduce their risk of developing certain cancers. And then when we know that there's the variant, then this is when we can offer predictive genetic testing to at-risk relatives. So the R207 panel is looking at inherited ovarian cancer. So this is where there's high-grade non-mucinous epithelial cancer at any age, and various other criteria there. And this will include BRCA1 and BRCA2, but also include some of the genes associated with Lynch syndrome, because we know in Lynch syndrome there are associations with ovarian cancer. And then another one of the main panels that we will offer testing for is R210, which is inherited mismatch repair deficiency or Lynch syndrome. And this is looking at variants in 4 of the main genes associated with Lynch syndrome. And there are many more criteria here, but I'll come on to the next slide. This is quite a busy aspect of the test directory, so I think if there are any concerns, just refer in. But some of the red flags for inherited bowel cancers are if an individual's been diagnosed with bowel cancer under 50, perhaps an individual who's had more than one related cancer, so bowel cancer and endometrial cancer, several close relatives diagnosed with bowel cancer, and if they've had multiple bowel polyps. And this slide is just a little overview on Lynch syndrome. So this is an inherited predisposition to one of the DNA mismatch repair genes. It's associated with an increased risk of mainly bowel, endometrial, and ovarian cancers. It is dominantly inherited, as are most of the cancer predisposition syndromes. And it's associated with accelerated tumor development. And tumors specifically have DNA microsatellite instability and loss of expression of specific MMR genes. So one of the tests that we recommend that is done before somebody's referred in is doing the immunohistochemistry of the mismatch repair proteins. And if there's any loss of expression of those proteins, then it's indicative that this could be Lynch syndrome. And this is a fairly typical family history or family tree of a family with Lynch syndrome. On the right are some of the cancers associated with Lynch syndrome. So in the middle, your patient diagnosed with endometrial cancer at 38. Her father had bowel polyps at 50. Her paternal uncle had colorectal cancer in his late 40s, and grandmother had endometrial cancer at 50. If you have any patients who report any similar family histories, then this would be a bit of a red flag and important to refer to genetics. So this is our leaflet on Lynch syndrome. And again, you'll see that compared to the general population risk, the bowel, womb, and ovarian cancer risks are significantly increased with these genes. PMS2 gene variants are associated with a lower risk of cancer compared to the others, but they will all, at present, we will treat them fairly similarly. So how we manage individuals with Lynch syndrome, so the risk of developing bowel cancer is significant, and so we'll actually offer colonoscopies every 2 years from the age of 25 or 35, depending on which gene, up to 75 years of age. And there's the option of taking aspirin every day to reduce the risk of developing bowel cancer. That's been associated in patients with Lynch syndrome. To reduce the risk of endometrial and ovarian cancer, then there is the offer of a hysterectomy with removal of ovaries and fallopian tubes from around 35 or 40 years, and only if that patient has completed their family. And then we ask the GP to arrange a one-off bacteria test for Helicobacter pylori, which can be associated with increasing gastric cancer risk. So that can be eradicated through antibiotics. There are other more rare inherited bowel predisposition syndromes, cancer predisposition syndromes. All but MAP are dominantly inherited, and in MAP, an individual needs to have variants in both copies of the gene in order to be affected with the condition. And here is just a list of some of the other inherited cancer predisposition genes. I'm not going to go into all the details, but suffice to say, if you have any families where there's an unusual pattern of cancer, then you can refer to our criteria for referring, or you can just contact us, because anything that's slightly unusual may be associated with a rare condition. And there are many more than I have listed here, but the test direct here again is the place to look. So I've just 2 more slides, summary really of what we do in genetic counselling. So we work as part of the healthcare team as genetic counsellors to help individuals understand the genetic contributions to disease. We assess the personal and family medical history. Our role is to interpret genetic test results and thereby diagnose genetic conditions. We assess the recurrence risk of other cancers in that individual, and we educate the families about inheritance, test options, management of the condition, and provide resources for information. And integral to our role is counselling and offering support to promote informed choices. So all genetic services will have slightly different ways of how you refer in, but important, if you can, to ask the patient to complete a family history questionnaire, to send that in with the referral letter. If you can, include any histology reports. That's less important because we can access those. If immunohistochemistry has been done on a bowel cancer, that's really helpful to include. And if you're referring to us, then my details are at the bottom, but otherwise your local genetic service will have specific ways that they want you to refer in. done.
Wow, thank you very much, Atlee. That was a great overview of the genetic counselling process. We don't have any questions yet, but if you're happy to stay, hopefully we'll have some questions at the end. So our next speaker we have now is Donna Gillen. So Donna, are you ready to talk?
I am.
Do you want to take control?
Yes, if you hand it over to me, I shall take control.
It's not coming through.
There you go.
Right, you should have control now.
Brilliant, thank you. There I am. So my name's Donna. I'm the Teenage and Young Adult Cancer Research Project Manager for teens and young adults with cancer, which we refer to as TYA in the West Midlands. Is my not moving? Is my slide moving your end?
No. Yeah, now it has.
Okay, maybe there's a little delay. So what I'm going to do, I'm going in a slight sidestep here, I suppose, to talk about a unique group of patients in the light of genomics. And I think a lot of what's already been spoken about is obviously 100% relevant and hopefully will echo with what I'm talking about here. So I'm just going to quickly introduce you to what the TYA service does, what my role is, why I've been given this project to perform, a little bit of context about cancer in young people, and the link into genomics. And when I talk about teens and young adults with cancer, we're talking about young adults from their 13th birthday through to their 25th birthday. So I'm firstly going to introduce you to the service. These services are regional, so there are different regions in England that have their own TYA service, as does Scotland, Northern Ireland and Wales. They're holistic, multidisciplinary services. There's a list of the different specialists that are employed and work within the service. And the aim is to supply age-specific care. The way that it's set up in the West Midlands is we have two principal treatment centres. 13 to 16-year-olds will be treated at Birmingham Children's Hospital, and 16 to 25 at the QE, which is where I'm based, or UHB. We also have designated treatment centres around the area where patients can choose to be treated a bit closer to home. But all of patients of this age with a diagnosis of cancer should be referred into the service, and there is a weekly MDT to discuss their care, particularly their psychosocial care, and to ensure that they're linked in appropriately as they can be. The patients can refuse specific care. They may not want to see a social worker or see a TYA nurse or a teacher, but we prefer them all to be referred in. So if you have any of these patients in your care and you're not familiar with the referral process, then please get in touch with us. So the aim of the service, got very sluggish slides. There we go. Is really to give support. And every day, 7 young people aged 13 to 24 will hear the words, "You have cancer." In the West Midlands, that equates to about 200 new diagnoses every year. And the evidence shows us that the TYA population often report a poorer experience of care, and that they can have poorer outcomes from treatment, poorer access to clinical trials, and more frequent side effects than other groups. The reason my role was created was on the back of NHS England's service specification last year, and that has mandated that by 2025, at least 50% of all teenagers and young adults with cancer will be recruited into a clinical trial. 100% of service users must be offered the opportunity to bank their samples, and that we should endeavour to embed genomic medicine within the TYA cancer service. So are young people with cancer different from other cancer patients? And the answer to that is a resounding yes, they are. We've all been either teenagers or young adults ourselves, or we may still, some of the people listening in may still be within this group. It's a time of rapid growth and rapid change on a physiological, psychological, and social sort of context. And I think the main thing is that we're also now beginning to understand that the biology of malignant diseases in this age group is also quite different, and it does respond differently to treatments that are given to children and older adults. From a clinical research perspective, there are very few teenage and young adult specific clinical trials. Most of the treatments that are being given to this group have been trialled in the adult population or in the children population. So because of the physiology of going through puberty and into young adulthood, the way that their bodies respond to treatment can be quite different. So this is quite significant. So what are the statistics? So bit of a busy slide. On the left, it details the cancers that are most often seen in this age group. And I draw your eye right down to the bottom to begin with. And I think you can see there's, we go through all the different diseases, and then at the bottom, we've got other 6%, which is almost equivalent with leukemias at 9%. And those others don't fit. They don't fit in. They're the rarest of the rare. They don't really fit into the other groups of diseases that we see here. I've already spoken about the number of young people that are diagnosed with cancer in the West Midlands, and this statistic here at the top on the right puts it at a national level. Basically, for all the cancer diagnoses nationally each year, about 1% are in this age range. So this is a minority group, which is good because we don't want young people to be developing cancer, but also it brings problems because of the lack of understanding of why these cancers grow and how to treat them. Having said that, survival in children and young people has improved for most cancers. More than 8 out of 10 young people diagnosed with cancer survive at least 5 years, and many of these are often cured. I think we need to remember with that to have a cure for a young person to have a cure from cancer, they've often had extremely intensive treatment. And that treatment can leave them with morbidities that they can be with them for the rest of their lives, whether this is an impact on one of their systems, like their kidney or liver function or lung function, whether it's fertility or whether it's their immune response. And there can be an increased risk of a second primary later in life. The highest survival rates are seen for Hodgkin's lymphoma, retinoblastoma, germ cell tumours, skin and thyroid cancers, with over 90% surviving 5 years after diagnosis. However, there are several cancers that have poorer survival, needing much more research and better treatments. And notably, some of the brain cancers, bone tumours and soft tissue sarcomas are within this. And that cancer remains one of the main causes of death in under 25-year-olds. So just to zone in a little bit on those hard to treat cancers, which are the brain cancers, bone tumours and soft tissue sarcomas, the question really is why? Why are they much harder to treat? And this slide gives 2 reasons. One is histological heterogeneity, meaning that there are different gene variations which cause the same disease or condition. So as has been explained earlier in the webinar, for most diseases now, we can look at the molecular pathology and work out what has happened at a DNA level that has created an environment for cancer to grow. And that environment, those changes, those genetic changes can become targets for different types of treatments, different types of drug treatments, different types of radiation treatments. If we come back and look at sarcomas, for instance, you can have like 5 people with a diagnosed sarcoma, but the genetic changes that have caused those sarcomas to grow can be very different. And this impacts that option for targeted treatment. It also impacts the risk of drug resistance. There's much higher drug resistance in these diseases, and also assessing their response to treatment and also their prognosis is much more difficult. The other reason on this slide is the low incidence of these cancers. These are rare cancers anyway. I was the adult brain cancer research nurse for a period of time, and it's a rare cancer anyway, but you bring it into this particular group and it's even rarer, and that means that there's less research, there's less understanding of why these cancers occur and how we should be treating them. So linking this into genomics is obviously, from the talks that we've already had, completely linked into genomics. And I've just got two papers here that really illustrate this. One is, this one is from the, it's a review of adolescent and young adult brain tumours in 2022. And it's really saying that molecular profiling, look at the genomic changes that cause these cancers to grow, is the future. It's the way that we will develop new trials, and it's also the way that we will be able to look at an individual patient and hopefully target the right treatment for them. This second slide, when it comes, is from Cambridge University Hospitals, and it's a summary of a review looking at whole genome sequencing that was done over 2 years in the diagnosis and the management of sarcoma. And their results are that whole genome sequencing resulted in a refinement in the diagnosis in 37% of cases, identification of a target for personalised therapy in 33% of cases, and a germline alteration in 4% of cases. And they concluded that the introduction of whole genome sequencing poses logistical and training challenges, but offers significant benefits to this group of patients. So whole genome sequencing is available. I know it's been mentioned that it's available for all children. It's available for all young people under the age of 25. Next slide's not come in. It's thinking about it. There it is. So it's available for all patients with cancer under the age of 25, which is really important. I think it's already been detailed that there's various reasons why, from a clinical utility point of view, the speed at which these patients are treated can sometimes not leave time to get that genomic sequencing data back. However, for the harder to treat, particularly with these patients, the harder to treat cancers, they know they're going to relapse. So having that genomic sequencing done as soon as possible as able means that information hopefully will be there further down the line to try and look at personalising the treatment for that individual and looking at what clinical trials may be available at that point. The other option for someone who is offered whole genome sequencing is an additional consent to donate genomic sequence, health data, and any remainder samples to the National Genomic Research Library. And this is basically a tumour bank, and this gives the options for the researchers, the scientists, to access this information, and which is really important when you've got such rare cancers, and to try and find some of the targets that can be used for effective management. I've also added on here that there's another tumour bank called Vivo Bank. This is the UK's largest biobank specifically for young people. It's another consent, but it allows Vivo Bank to then contact the NGRL or other biobanks. A lot of orthopaedic hospitals have biobanks. Clinical trials will take tissue for biobanking, and this allows Vivo Bank to collaborate with all of those other biobanks to ensure that young people are being prioritised when it comes to research and biobanking. So this slide, this is actually the landing page for a new website, which I'll talk about in a minute. But the thing that I love about it is the way that it's put all of these options in a row like this, and explains them really simply. And it's showing perfectly that biobanking or tumour banking allows the scientists to, so we're looking at translational medicine really, aren't we? We're looking at bench side with biobanking, so the scientists can have the samples to try and work out exactly what's happening, why are these unusual cancers growing, and then to feed into the ideas that create the clinical trials, which brings research from the bench side to the bedside and hopefully brings more effective treatments for our young people. And then right smack in the middle there, we've got genomics, which is the thread that goes through all three of these options. This site, well, that site, I would encourage you, if you do look after young people, to have a look at that. It's only been in existence since July, but it's been created by young people and nurses, and it's got some great videos explaining to young people why they should know about genomics and biobanking and clinical research. So it's a good one to go back to. I've got a couple of quotes here that have been taken off the Teenage Cancer Trust page, just to remind us that there are individuals at the end of all of the decisions and the work that is done within healthcare. I just thought it was good to put a couple of young people's comments in here. So Rachel, who was 15 when she was diagnosed with giant cell tumour of the skull bone, says, "We have the rest of our lives ahead of us and shouldn't be allowed to suffer because we don't have access to the right drugs." And Verity, who was diagnosed with a rare sarcoma at 17, is saying that the best advice I've had is to stay alive as long as I can, because by then more drugs might be available to treat it. And I think that's a very definite challenge for healthcare professionals, that we are aware of this minority group and that we ensure that they are considered when we're moving forward with genomic care. Last slide is coming up. Very big delay. There you go. So I just want to put this up here as well. If anybody does work with young people, I'm quite keen to work towards having some better information for them around clinical trials biobanking and genomic testing. So I'm asking for their opinions and their experience. So if you do have a population that you could share this with, I would be really grateful. And I think that that's me. So thank you for listening. If there's anything that I've said that has struck a chord and you want to get in touch, then please do. And I think I've caught you up a little bit of time. So thank you.
Thank you very much, Donna. That was really interesting and really an important subject to be thinking about when we're talking about genomics, especially with young people. So our next speaker, we really are very honored to have our next speaker. And if I can open up my slides again. We have got the very inspirational Amina Westwood, who is an expert by experience, who is going to talk to us about her journey and the work she's now involved with. So Amina, are you ready to go ahead? I'm going to stop sharing because you've got no slides. So yeah, okay. I'll stop sharing.
Firstly, I've listened to the whole webinar, and it's like, wow, what a difference you professionals are making for us. And all we can do is say thank you so much. I'm going to be very honest, very open, hoping that it will help in the future, guide people, maybe think about their approach. As I said, everything that I say is my personal journey, my family's personal journey. So some of you might like, oh, what is she saying that for? But this is how we feel, and this is really important. I found that sharing my journey, I hope, raises awareness, not only for professionals, but for communities back to grassroots. So my cancer journey, from a very little girl, I remember my grandfather having cancer, and then as I grew up, I remember my dad telling me about all his brothers. This one had cancer, that one had cancer, this one, you know, it spread to his brain. So as a child, cancer was always spoken about. But in 2016, 3 days before I married my husband. I'd been this bride ordering flowers to present to my mother to say thank you for helping me on that very emotional day. And I found myself on the day of the wedding, we'd only just found out that she'd got breast cancer. She had lobular breast cancer, not finding the words. The words wouldn't come. I just remember handing her the flowers and hugging her, because unfortunately, across the board, when someone hears the word cancer, they straight away, they assume that this person will pass away. So that was in 2016, and my mom went on to have a lumpectomy, and she had radiotherapy, and then she was put on the hormone medication. Little did we know that 1 year later, I would be diagnosed with lobular breast cancer. And it shocked us all, because we were like, well, we're told mum's cancer was rare, and for me to get it only 1 year later, straight away we presumed that I must have inherited it from my mother. So I went on, I had a mastectomy and reconstruction. And as my onco result came back at 14, I didn't have to have chemo. So I had radiotherapy and I was put on tamoxifen. Both times going to breast clinic, we kept, we were asked about genetics, and we asked about genetics, and we filled in the relevant forms of who we had in the family, and that nothing ever came of them. Those forms, you just get the letter saying, oh, nothing to worry about. Then in 2018, my father was diagnosed with stomach cancer. That was a very hard thing for us. And he had to have his stomach removed. And while he had his stomach removed, this is in 2018, he had been approached to be part of the 100,000 genomes trial, and he agreed. I had no idea he did this, but so he had his stomach removed. He decided not to have chemo or anything. I think he was 86 at the time, and I think he just wanted the quality of life rather than the quantity. He didn't want to be sat there throwing up and feeling ill. So he managed, in the time that he had, to go and do his pilgrimage. He managed to travel to Yemen and say his goodbyes. And he was so brave. He shared his story with many as well. So my dad passed away. Sorry, I always gulp at this stage, but my dad passed away July 2019. So we've gone from 2018, when he did the trial, to in 2022, November of 2022, being reached out to tell us that my father was a carrier of the BRCA2 gene. So that was a shock to us all. And then to find out that his children, he has 6 children, out of those 6 children, it could be 50-50, as you all know. I don't need to tell you that. So out of the 6 of us, one of us didn't want to know. She lives in Yemen and she didn't want to know. One of my sisters didn't carry it, but 4 of us have. So that's my brother and myself and 2 other sisters. Now, just before that happened in November 2022, one of my sisters, who now we know has the BRCA2 gene, was diagnosed with breast cancer. She was living in Kuwait at the time, and so she had a lumpectomy, etc., and then put on hormone tablets. And then her identical twin, who lives here in the UK, went to breast clinic and said, look, I'm ever so lumpy and I'm really concerned because my identical twin has just come through breast cancer. Is there any chance I can have my breast removed because I want to live? I've got a young child and I want to be there for that child. And to be totally honest, she was brushed off and she was told not to be silly, that she was low risk. So then you can imagine within a couple of months of being told that, even though we all had a gut feeling there had to be more to it, there was so much cancer in our family. And every time we filled in a genetic form, nothing ever came of it. So when that genetic phone call come to say that we'd all got this BRCA gene, finally she was taken serious. And by the time that the lumps that she told them about were checked, on the one side she had a 12-centimeter breast cancer, and on the other breast, she had it in both breasts, she had a 5-centimeter breast cancer. Now, on my journey, I keep looking back thinking it was too late for me to find out, because my dad did the genome trial in 2018 and I was diagnosed in 2017, and I keep thinking to myself it wouldn't have made any difference for me. And then now when I look back, I think yes, it would have, because I decided 2.5 years into my tamoxifen that I wasn't coping with it. So I went back to my oncologist and I said to them, I'm really struggling with this tamoxifen. What are the statistics? And the statistics were a 7% chance of me ever getting another cancer. Now, remember, we're talking prior to me knowing I've got BRCA2. So I made a big decision. I thought at 7%, I came out with some ridiculous comment to the doctor saying, well, I live in such an area, I could get hit by a bus and that. And that's how I looked at 7%. So I stopped taking tamoxifen at 2.5 years. That was a personal opinion on the statistics that I was given. And now when I look back, I'm very, very frustrated, because as I sit here in front of you all now, I have metastasized breast cancer that has spread to my bones. And yesterday, I went to have MRI on my brain because my cancer markers have started doubling. And I look back and I think to myself, I wasn't 7%. I was actually at 88% chance of a reoccurrence of my breast cancer. 88% chance of me getting another primary cancer. And I look back and I think if the results had come through quick enough, I wouldn't have come off that tamoxifen. And if the results had come through quicker, my 2 little sisters would have had preventative mastectomies, so they wouldn't have ended up with the breast cancer. When it came to genetic testing and how once we were on that system, I can't fault the team. Beautiful lady called me, and explained everything just as we were told, about how they call up the counsellors and speak to us and advise us. I cannot fault. From that point onwards, I can't fault. But feeling very let down that we weren't listened to where I am now with terminal cancer, I'm frustrated. I am very proud of my father for agreeing to be part of a trial, because he's given me the tools and the knowledge to be able to prevent it in my children. So my daughter tested and she tested positive, and 3 weeks ago she had a double mastectomy. The anger, the guilt, it's all there. I feel like a terrible mother that I've given this to my daughter, and I'm determined to get my boys to go and get tested. But there's something about boys and committing to these things that has been a real big challenge for me. But because I don't know how long I've got, I'm determined to get the boys to go and get tested, because they owe it to their daughters and their children as well. So one thing that I've found that has helped me on my journey is raising awareness, putting my experience on a platter for everybody to ask the questions, to hopefully change mindset. I try to get involved with as much as I can. Here in the West Midlands, we have something called Go Hilders, and I've been so honoured to be part of that, trying to find the best way to get back to grassroots, to go and raise this awareness. Because one thing in our communities that is very much so is it's a taboo. We don't talk about it. We don't have cancer and we don't have mental health, but we do. So I'm on that challenge of trying to change the way things work and how our communities think. But I still feel there's a big, heavy load on yourselves as professionals. I tell people day in, day out, I'm the founder of a cancer support group called Let's Talk Hope. I tell people, you know your body better than anybody else. So when we get to you professionals or our surgeons and that, we need you to listen. If you'd have listened to our family back in the day, maybe I wouldn't be sat here in front of you saying, you know, this is like, it's terminal and such. So I think for me right now, it's trying to raise awareness, trying to get information. I've just joined a new project and I am so proud of it. It's the Community Cancer Connectors with Macmillan, and we are bringing it back to grassroots. We are telling our communities, we are giving them the knowledge to safeguard their families. So if you can hear the frustrations in my voice, but know that I've spoken from my heart, that please listen. Please, we know what we're talking about. Don't brush us off. And criteria, I'm sick of criteria. There's a new drug that's just come out, well, this year for people with cancer like myself, metastasized breast cancer, that have got the BRCA gene, but I couldn't start on that because I had to try this first one first because it's part of the criteria. And now 2 weeks ago, I was told my cancer markers are doubled. So obviously that first drug wasn't working, but because of the criteria, you have to go through this to get to this. And I think if I could say anything to you, please stop muddying the criteria. Please listen. And I hope me being so open with you, it shouldn't have taken 4 years for us to find out that my dad had BRCA too. So I'm hoping that me sharing my very emotional and angry journey and frustrations, that we can make a difference. The 100,000 genomes trial, thank you. It's, yes, I'm angry slightly because of the delays, but at the same time, you've also let me have the tools so I can safeguard my family. So there are pros, there are cons, and I just hope that my story will help somebody. Thank you.
Thank you so much, Amina. That was such a honest, personal, emotional talk you've given there. I find you very, very inspirational. So thank you so much for sharing your story. What a way to end. Really, I think now going on, we've got I'm just checking to see if we have got any questions in the chat, and lots of thank yous there, Amina, if you can have a look in the chat as well. But looking at the questions, first of all, just thank you to all the speakers. The really important information that we've got there, and a great overview, I think, of cancer and genomics in cancer care. So there is one question we have here from Beatrice, and I think this goes out to Atali, and it is, what is the current wait times for cancer patients referred to clinical genetics for pre or post testing in this genomic era?
Hi, thank you. So Beatrice, I see that you're based in Barts, so my answer may not be relevant to the London Genetics Services. However, if there's a patient who's going through active cancer treatment, there will be mechanisms for expediting appointments and genetic testing. So I have a colleague who sees patients urgently and arranges urgent genetic testing. And so a result, for instance, for BRCA testing, R208 will be available within maybe 4 or 5 weeks from referral, which will then help their treatment options, because if they're eligible for PARP inhibitors, that will be available when it's part of that pathway. In routine care, though, if there's a patient who happened to have had a cancer many years ago, then we will treat them more routinely, because it's not going to impact them directly for their cancer treatment, because that's been completed. So there will be mechanisms for expediting services. And so if you have questions, contact your local genetics service, see who it is who can arrange that for you. There is also a drive for what we call mainstreaming. So genetic testing is happening at the point of diagnosis within oncology. And this is a new sort of pathway that's occurring. And this is to help to streamline things, to reduce waiting times. So the clinicians who are trained, the oncologists who are trained in this area, will know what the criteria are. And within all around the UK, there will be people who will be doing this mainstreaming there and then. So I hope that answers your question.
Thank you very much, Atlee. I think I have another question, and this goes out to David, if David is still on the call. And really, I have a question. There's all this research that's going on. So what are the biggest obstacles in translating cancer genomic research into widespread clinical practice?
Yeah, personal opinion. It's a great question, and it's something that we're grappling with. I think it's infrastructure and people really at the moment, and I mentioned it briefly in passing, but if the funding is there for the genome sequencing, that's all well and good. But if you imagine you're analysing a huge amount of data, and it's substantial time and effort required to understand that. You think about all of these subtleties that have to be taken into account. If there is a variant, is it pathogenic? Predicting tools are not always perfect, often far from perfect. And what does it mean for the patient in whom the test is being done? These things take substantial time and effort, and the clinical scientists are better placed than I am to weigh in on that. But it's a real challenge. I mean, there's some feeling, I think, in the community that as AI methods become more mature, that they will help us with this. I'm sure they will, but it's not a panacea. You need to be confident that the AI is performing to clinical grade, because ultimately it sounds a bit trite, but it is people's lives on the line, and we always need to bear that in mind in clinical care, don't we? You can't have an AI model hallucinating like we read about in the popular press, because that could be fatal for someone if you have a mismanagement. Yeah, so it is a challenge.
Thank you. And Laura, the question I have, which I feel you have answered, but maybe just to maybe make it a bit clear for me, is the logistical challenges in ensuring that genomic testing results are returned to clinicians in a timely manner, especially in urgent cases. And I know you've spoken about the whole genome sequencing, but are there challenges with non-whole genome sequencing genomic results getting back to patients? Is Laura still here? Okay, I'll get back to Laura for that question. With Donna, my question is, how do socioeconomic or ethnic disparities affect access to genomic testing and personalized care for the young people, cancer patients?
Good question, Phil. Exactly the same way as they do for adults and children's. I think it's just that because young people are such a unique population, that if you add on their age to the fact that they may have other reasons why their care is inequitable, then it actually sort of just like starts to snowboard, doesn't it? There's lots and lots of reasons why for some people accessing good care is really, really difficult. And I think the work that you guys are doing is really important because it's about raising awareness. And I think the project that I've taken on, a part of, I mean, I've spent 6 months just trying to work out what's happening, but I think a lot of the role is actually just about awareness and getting out and talking to people and sort of shining a light on what's happening for minority groups and why they need to be considered. And in this big wave, this big evolution, I like the evolution and revolution. I agree with David, and it's definitely evolution. And I think in this wave of evolution, I think we need to make sure that all the people that sit slightly outside of the majority are included. So yeah, there's a lot of work to do, but I think as long as we as healthcare professionals are aware and we're looking at our patient groups and doing the best that we can for them and listening to the people that know, like Amina, who've actually gone through these experiences and collaborate together, then hopefully we can move forward.
Thank you, Donna. And finally, Amina, I'm going to end with yourself. I can't see any other questions that have come through, but I had asked you a question earlier, which you've answered, but I have one more question, and that is, what is the single most important thing that you want healthcare professionals to be aware of?
Okay, as I said, we tell people, and even doctors tell people, you know your body better than anybody else. I think it's listen. But also I think there's an add-on to that, because we're all finding all these barriers, whether it be a language barrier, whether it be a custom or any of those. I think people need to look at that and think, could there be a barrier here that the patient or the person isn't being so open? As I said, a lot of the communities that I work with, and in this new project that I'm being launched on Friday, it's about breaking down the taboos and that. So I think if I say to doctors, go and work with communities, because you'll get the honest answers there. I think I've always said, bring it back to grassroots, whatever it is. Yes, you've got all the scientists and all the posh diagrams and that, but we know our people better than anybody else. So that's, I think, listen and come back to grassroots.
Thank you very much. So once again, thank you so much to all our speakers. I hope for all that have joined that it has been an eye-opening session, and that you've got more information about genomics and the impact genomics is now having in cancer and rare disease as well.